Video is a continuation from the previous Pearl Index video. But this one for part 1 MRCOG. So what is implanon? Basically, implanon is an implant that contains ethanogestrel, about 68 milligram, and it will slow release of the ethanogestrel for 3 years. So with the very good Pearl Index of 0.05%, and the price, I think it's around 3 to 500, depends on where the patient insert this implant. And how the mechanism, basically it's first it's inhibit ovulations by giving negative feedback to GnRH with a high level of progestogens. So GnRH will be inhibited, so thus the FSH and the LH altogether. Secondly, it will thin the endometrium, or it's become atrophic endometrium, which cause the presentations of the patients. After using this, 20% of them will have a total amenorrhea for 3 years. 20% of them will have irregular menses, so only spotting, and 5% of them will have a infrequent bleeding. So what are the mechanisms that makes implant number first in the Pearl Index? Is because it's also reduced the peristalsis of the tube. As we know, in the fallopian tubes, we have a microvilli that helps the implantations of the fertilized ovum. So because it's reduced the peristalsis, so it's reduced the pregnancy itself, and also it does not help the sperm to swim up to meet the ovum. So the fourth one, all of this causes the reduce in the implantation. So usually for ethanogestrel, what will be the setback? 70% of the patients will have a weight gain. This is because of the water retention and also increase of the appetite. It's about 2 kgs every year. So if you gain more than that, it's not the implanon, it's actually your habits. So secondly, in the Pearl Index is the IUS, or intrauterine system, or Mirena. So Mirena, it does look similar to the intrauterine device like copper, but the difference is it contains the levonorgestrel. So levonorgestrel, it contains 52 milligram of levonorgestrel, which lasted for 5 years. So it's only slow release of 20 microgram of levonorgestrel per day, making the Mirena is second in the list of the effective contraceptive methods. So we call it a long-acting reversible contraceptive methods, because, and the price is for in Malaysia, it's about 530 ringgit. So it's very safe if you calculate only 100 some plus for 1 year. So what is this? It's actually still have the same effects on the endometrium. It's inhibit ovulation as well. And secondly, it thin the endometrium. And then it increase the phagocytic cells in the endometrium, making it unsuitable for implantations. And the good things about this, it's increased the cervical mucus viscosity. So it will be difficult for the sperm to swim up in the cervical canal itself. So it's too thick that the sperm cannot really swim up and penetrate through into the endometrium. And actually, even though it's inhibit ovulation, 75% of the patients or women who's on this method still continue to ovulate, can ovulate. So the good thing is about this is that it has a local effects. So they don't have the weight gaining, the headache, the bloatedness that the patients sometimes can experience while on implanon. Okay. What about the setbacks about these methods? About 60% of patients might have irregular menses or bleeding, especially in the first 6 months of incisions. Irregular menses of bleeding over the 6 months, and after that, the patient sometimes can have amenorrhea, which about 60% of them will have amenorrhea after 12 months. Okay, let's move on to the next, which is BTL. So BTL is actually a sterilization, but the pull index is actually not as good as the Implanon and also the Mirena, where for the Mirena is 0.2 and for the female sterilization is 0.5. So it's actually a higher group of women who actually get pregnant, accidentally pregnant after the BTL was done. So if we talk about BTL, usually it can be done as during the same setting with the LSES cesarean sections, especially in the repeated cesarean sections cases like 2-3 previous CAR or 4 previous CAR. Usually the doctor will offer to do at the same settings, but this of course has some issues because during pregnancy the mesovarium is actually more engorged and leads to bleeding. So if let's say you've encountered patients during cesarean section with very engorged mesovarium and difficult procedure if you want to do BTL, then probably you can reconsider at the intervals, which is 6 weeks after the postpartum. You can start actually to offer the patients to have elective BTL. It can be done laparoscopically, or it can be done mini laparotomy. This actually the most the setback about this is actually regrets. As we know, in our current society, sometimes the women at 35-year-old get divorced and remarry to another man and wish to have another pregnancy, but they already did BTL. So for those who less than 30-year-old, usually we have to think of other methods of contraceptions because we have two better contraceptions up here that we can offer to the patient, so and less risk to the patient. So other than the regret, some of the patient will go for tubal reversal procedures, which actually offered especially in infertility center. I have encountered at least 3 cases of a patient who had done BTL and asked to reverse the tubes for the infertility matter after remarried to another man. So basically, it's something that we have to think of before we do these procedures, because the current world that we are living today is actually very dynamic, changed, and our practice also needs to accommodate with this change. But of course, there is some indication, especially for those who can't use Implanon and also Mirena. For example, those with breast cancer, breast CA, we don't really we can't. It's a contraindications for them to use this hormonal contraceptions. And for those actually with active PID, for example, pelvic inflammatory disease, probably Mirena is not the best contraceptions to use at that point of time until they settle the PID. So one of the methods that and for example, at the same time the women experience heart disease, for example, or stage 4 kidney disease, kidney failure. So basically you can offer BTL if it's really cause harm to the mother. So what after the BTL? It's actually intrauterine contraceptive device. Usually it's a small and it's a copper base, and this because it don't have the progesterones here, so the effectiveness is slightly lower as compared to Mirena, because the pill index is only 0.8%. Not so bad, not so far away from IUS, but yeah, the ICD. So I guess ICD, basically what it does is that the ICD, how the mechanism is quite straightforward. Copper is actually toxic. Copper is toxic to ovum and also sperm. So this will inhibit the fertilization, and it will inhibit, as it's occupy the endometrial cavity, it will inhibit the implantation as well. So that is why it's quite effective here, and it can last, depends, up 3 to 5 years, and it's actually very cheap. It's only 80 ringgit for 5 years, so it saved a lot of money on this. But what will be the risk for the patient who's actually on ISCD? So the first one, we talk about the expulsion rate. So that is why in our COG, we actually gives a time window for this. The expulsion rate is about 5%, but we recommend to insert it 48 hours after delivery of the placenta up to 4 weeks. If you didn't insert the ICD after 48 hours, then probably it is best to wait until 4 weeks to reduce the rates of expulsions. What about the perforations? The uterine perforation in regards to the ICD is actually about 1 in 1,000. So it's only 0.1%. It is a statistic that you can quote. There is a risk there. That is why we wait until 4 weeks to reduce this risk. And what about the PID? Basically, it won't actually increase the risk of PID, but if the patient has sepsis or active PID, we don't recommend to insert more foreign body in the uterus. So, and the patient can have some 30% of them, will have irregular menses. Move a bit. But the good things about this, since it's non-hormonals, it's actually not really changed the menstrual pattern. Okay, so next in the line after ICD is our POP, COCP, and also patch. What's the problem with this? Let's highlight on the COCP first, because it's actually the most senior way of contraceptive. So for COCP, the issue will be in regards to this. Basically, COCP also will inhibit ovulation. Usually, it contains 21 active pills and 7 sugar pills. And the problem with this, usually the compliance of the patient, because they have a very small window for this. So if, let's say, the patient takes the pills at 8 a.m. and forget to take it within these 3 hours, so they only remember at 2 p.m. So basically, it's considered as a missed pill already. But for POP, some of the pills like Cerazette, it has a bigger window. It's about 12 hours, so this can help the compliance issues. But still, the patient needs to take it regularly, and the reason why it is not as effective as other above methods is because of the compliance, and about 6% of patients will still accidentally pregnant on these methods. But the COCP, the problem is that there is a few contraindications. First one is it can increase the risk of VTE or venous thromboembolism. So we want to avoid this if we have the high risk to get VTEs in the patient. And comparing the pills and the above methods, basically this usually we advocate to if the woman is breastfeed the baby, basically we advise them to use this after 6 weeks of post-delivery. Postpartum, start to use these methods, because before that you can, if breastfeeding, then it can covered by the lactation seminorial methods, LAM. So a frequent LAM, lactation seminorial methods, basically 2 to 3 hours feeding if the mother does not experience any PV bleeding and they didn't mix up with the formula milk. Basically LAM can cover the first 6 weeks. But if the woman is not breastfeed, then we advocate to use this less than more than 3 weeks. Then they have to start to use this type of contraceptions, while the above methods basically does not disturb the breastfeeding, and also it can be inserted right away after the delivery. And this is contraindicated in patients with who have a high BMI of 35. As we know, higher BMI will have a higher risk of VTE. And the third one, let me move a bit. If the woman is smoker, about a heavy smoker, 15 cigarettes per day, then it is best not to use this method as well. What about other contraindications like cardiovascular disease, CVD? It is best to avoid this as well, because it's increase the rate of ischemic heart disease and also stroke. And what about the patients with hypertension? It is also uncontrolled hypertension. You don't advocate to use this method as well, as in regards to the COCP. And also the patients with valvular heart disease and also migraine. So it is among the contraindications of the COCP itself, like liver cirrhosis, SLEs, and etc. So there are fairly a lot of contraindications which actually absent in the other above methods. So what other after COCP? The barrier. The only good things about barrier is that it can actually protect from HIV and also STDs. This basically, if the patient's already contracted with HIV, basically we really advise the patient to use barrier methods as compared to others, because the above does not contain any protections to HIV and STDs. But the problem with the barrier is, of course, the risk of dislodge, and also it's actually perforated during the sexual intercourse. And the last one is the natural. Basically, all the setbacks. You just have to calculate when the woman is actually ovulating, so you can actually see on day 14 there will be some changes in the cervical mucus. You can see this pain Barker kind, which is a very thin and very elastic kind of vaginal mucus. Increase of the basal temperature. So you can see all those. I hope it helps.